Now, good afternoon. Now, this is another class. We are going to discuss another condition in pathology, and this is edema. Others call it edema. So that is our today's topic. So by introduction, what is edema? This is abnormal and excessive accumulation of free fluids in the interstitial spaces and the cellular cavities. The fluid in body cavities, for example, ascites, which accumulate in the peritoneal cavity, then androthorax or pleural effusion, which accumulate in the pleural cavity, or andropericardium or pericardial effusion, which accumulate in the pericardial cavity. Free fluid in interstitial spaces, that is spaces in between the cells. Now, let us see types of edema. Edema can be two types. It can be either localized or it can be even be analyzed and generalized. So what is localized examples of edema? Now, lymphatic edema, if there is a pathology in the lymphatic drainage system in the body, or inflammation processes which can cause edema locally, or allergic edema. Now, another one is generalized edema, where we talk about like edema because of the renal problem, like in patient with acute renal failure or chronic renal failure. We can have cardiac edema, like cardiac tamponade, or also we can have nutritional edema. This is because of raw albumin in the body. Now, let us see causes of edema. Edema can be because of increased hydrostatic pressure. That is, for example, impaired venous return to the body because of increased in the hydrostatic pressure, congestive heart failure, constrictive pericarditis, ascites. For example, if there is a liver cirrhosis or even a liver cancer, venous obstruction or compression of blood vessels, like in the thrombosis, external pressure, for example, an external mass pressing a blood vessel, which is returning blood back to the body. If there is lower extremities inactivity with prolonged independence, for example, if the varicose veins are weak, cannot be able to ensure the blood flow back. Atrial dilatation, for example, in heart, neurohormonal or dysregulations. So also there is another cause, which is a reduced plasma, or that is osmotic pressure, and for example, associated with the raw protein in the body, that is hypoproteinemia. For example, in a cases where patient is losing a lot of protein, like in glomerulonephritis, which is a nephrotic syndrome, which causes a loss of excessive albumin in the body. The other one is liver cirrhosis. Example is ascites. The other one is malnutrition, like for example, kwashiorkor, protein losing, or gastroenteropathies, conditions where patient is losing a lot of protein in the stomach. Another one is lymphatic obstruction, for example, in cases of inflammation, in cases of neoplasm, in cases of post-surgical or post-irradiation. Another one is sodium retention, like excessive salt intake with renal insufficient or increased tubular reabsorption, or sometimes drugs can cause this. Now, another one is inflammation, like in acute inflammation. You know that edema is a cardinal sign of inflammation, and also in chronic inflammation, and also sometimes in angiogenesis. Angiogenesis is a development of new blood vessels, which is a process of inflammation, which can result to edema because there is a lot of cells, a lot of blood vessels that we need to do some activities there. Now, let us look at the pathogenesis of edema. The mechanism is that there is interference in normal fluid balance of plasma, that is the blood, the interstitial fluid, that is the fluid in between the cells, and the lymphatic flow. You remember that lymphatic flow flows to the heart. So there, in this case, there is decreased plasma oncotic pressure, increased capillary androstatic pressure, lymphatic obstruction, tissue factors, for example, increased oncotic pressure of interstitial fluid and decreased tissue tension. So increased capillary permeability and sodium and water retention, for example, in intrinsic renal mechanism, in renin, angiotensin, androstenedione system, and in the androstenedione antidiuretic hormone mechanism. Now, in this flow chart is that you can see various ways of control or fluid regulations in the body. You can show the extrarenal hormonal. You can so see the intrarenal, and also you can see the antidiuretic hormone mechanism. Now, in this case, the patient has hypovolemia, low volume in the blood, most likely either by bleeding or anything else which can cause low. So in the process of extrarenal hormonal pathway, there is in this case there is a renal ischemia. The blood flow to the river, to the renal is reduced, and in this case there is reduced sodium in the renal tuberous. If there is reduced sodium in the renal tuberous, then the macular denser cells senses that there is less, or there is other sensors called neutramia, which senses the amount of sodium in the renal tuberous, and then tells the angiotensin start activating the renin system. Now the angiotensin then is produced, act on by renin, and then the activation of the glomerular apparatus, then angiotensin 1 in the plasma, which is act on by angiotensin converting enzyme. You remember there is drugs which work at this point, the ACE inhibitors. So they are this one is converted into angiotensin 2 in the lungs and the kidneys, and then androstenedione releases in the adrenal cortex, which result to increased sodium and water retention, resulting to a correction of hypovolemia, and then there is the normal blood volume or fluid volume in the body is restored to normal. Obviously, we don't talk of sodium and water, which can be either can result to blood pressure, increased blood pressure, or edema. Now, the intrinsic pathway is that there is hypovolemia again. The baroreceptors in the carotid and the aortic arc realize this one. Then the vasomotor in the brain is activated, sympathetic flow. Renal ischemia result to reduced glomerular filtration, resulting to reduce excretion of sodium, and this one results to a sodium and water retention, which can cause edema or increased blood pressure. So on the antidiuretic hormone mechanism, there is increased antidiuretic hormone production in the posterior pituitary gland, resulting to increased retention of water, which can later result to sodium and water retention, resulting to edema and blood pressure. So that is how the regulations, which can later to increase can cause to sodium or increased water retention in the body. That is how it is regulated. Now, let us look various types of edema. There is edema because of renal conditions. For example, these occurs as a generalized edema and we call it anasaka, and associated like a nephrotic syndrome. In a nephrotic syndrome, the patient is losing a lot of the albumin. Sometimes of glomerulonephritis, like nephritic syndrome, and also renal failure due to acute tubular injuries. So, nephrotic syndrome is characterized by persistent heavy proteinuria, especially the albumin, which causes hypoalbuminemia. This leads to reduced plasma or contact pressure, resulting in severe generalized edema, as there is activation of renin, angiotensin, and androstenedione mechanism, which result in retention of sodium and water. This vicious cycle, which persists for till the albuminuria continues. So classically, most severe in the subcutaneous tissues as well as in the visceral organism. So in this case, nephrotic syndrome, the patient loses the albumin, resulting to a fluid escaping from the vascular species to the interstitial species, resulting to edema. So in nephritic syndrome, the condition just as in acute diffuse glomerulonephritis or rapid progressive glomerulonephritis, that is a nephritic edema, there is excessive reabsorption of sodium and water in the renal tubules via the renin, angiotensin, and androstenedione mechanism, resulting to mirrored compared to nephrotic, it is mirrored and compared to nephrotic edema, begins in the rows of tissues such as on the face, around eyes and ankle, areas and genitalia. That is where these tissues that are getting lost. Now, the other one is acute tubular injuries like following a shock or toxic chemicals either endotoxins, heavy metals, all those type of things. So there is damage in the tuberous roots. They lose their capacity for selective reabsorption and construction of the glomerular filtration. Now, this results in increased reabsorption and oliguria. Since the patient is reabsorbing a lot of sodium, a lot of water back to the body, then this person is going to produce less urine. This is a case of acute renal acute renal injuries, where we say that if the patient passes less than 500 ml of urine less than 24 hours, then we start talking about acute renal failure. So acute kidney injury. So excessive retention of water and electrolyte and release in blood urea is what happens in this one, because there is no no excretion. The electrolytes stay in the body, especially the sodium, the potassium, and then also the urea. And this patient can start having what is called uremic encephalopathy. Now, let us look at cardiac edema. Now, the cardiac edema is that there is generalized edema caused due to right-sided congestive cardiac failure, right-sided and congestive cardiac failure. So, influenced by gravity-dependent edema. Now, in this type of patients, when they lie flat, they start having a cough, difficulty in breathing, so they have to stay in a propped up bed. So, in this case, there is reduced cardiac output resulting to hypovolemic, which in turn activates intrinsic renal and extrarenal hormonal, that is the renin, the RAS system, and also the antidiuretic system, resulting to sodium and water retention. So the back pressure hypothesis is that the right-sided heart failure elevates central venous pressure, resulting to transmitted backward to the venous end of the capillary. This one is called the before road, releasing in the capillary endostatic pressure, and consequently there is transduration. So forward pressure hypothesis is that there is chronic hypoxia, injury to the capillary walls. That means now there is what we call intrinsic pathway of inflammation, because the endothelial cells start in getting inflammation. They start now producing the endothelium, prostaglandins, histamine, small amount of heparin. They can also start activating the cytokines like interleukin-1, interleukin-6, interleukin-7, and also tumor necrotic factor. So in this case now the cascade of inflammation process starts being activated. And also in this case, again, in these capillary wall damages can also start activating what we call the coagulation pathways, the intrinsic pathway of coagulation. So this one causes increased capillary permeability and result in edema. This one, this diuretic supports the edema by this mechanism is exudative, whereas the cardiac edema is typically transducive. Now, this is an example of how the cardiac edema works. That, for example, you have a cardiac edema that is congestive heart failure. It can follow the three pathways. Either, in this case, in this congestive heart failure, can cause there is increased venous pressure. Increased venous pressure results to increased capillary endostatic pressure, which causes back pressure hypothesis. In the other way, it can reduce to reduced cardiac output. This reduced cardiac output results to hypovolemia, and this hypovolemia activates three pathways. It can activate the extrarenal mechanism of aldosterone, that is the RAS system, or it can activate the intrinsic renal mechanism. It can reduce the glomerular filtration rate, resulting to secondary to ischemic, renal ischemic, and also it can activate the posterior pituitary hormone, can start now acting where there is a production of antidiuretic hormone, which causes sodium and water retention. All these ones result to cardiac edema. And that one, because of the major pathology is congestive heart failure. The other mechanism is that it can be because of chronic hypoxia, which can cause to increase permeability, capillary permeability, due to, we have seen that because of injuries to endothelium, resulting to inflammation, and inflammation of the endothelium results to increased capillary. Now the blood starts escaping from the vascula to the interstitial spaces, and this one can cause a forward pressure hypothesis, or this one can result to what we call cardiac edema. Now, let us look at a pulmonary. Now, let us look at pulmonary edema as a cause of edema. So, in most important, is one of the most important form of bronchoedema. It is caused by a functional impairment, and the etiology pathogenesis is that there is elevation of pulmonary endostatic pressure due to increased capillary permeability. That means now, in this case now, there will be fluid in the alveolar spaces. And you remember very well that the alveolar spaces is the gaseous exchange point. Now, what will happen? In this case now, there is increased capillary membrane. Now the fluid start escaping into the alveolar spaces. And at this case now, the way the oxygen gets exchanged, now the patient, there will be what? There will be water. And this one is going to result to a problem and the patient will have a difficulty in breathing. Now, there is another one, which is elevation of pulmonary endostatic pressure as a cause of pulmonary pressure. In heart failure, there is increase in the pressure in the pulmonary veins, which is transmitted to the pulmonary capillaries. This is more called pleurode, or associated with what we call copulmonary, because it is cardiovascular condition which is causing this problem. So this causes imbalance between the pulmonary endostatic pressure and the plasma oncotic pressure. So excessive fluid moves out of pulmonary capillaries in the interstitials of the lungs. So this cleared by the lymphatic present around the bronchus and veins. As the capacity of the lymphatic to drain the fluid is exceeded, because there is excessive leakage in the alveolar spaces, then the fluid starts accumulating in the interstitial spaces. Now, prolonged elevation of endostatic pressure and due to high pressure of the interstitial edema, alveolar lining cells break and the alveolar air spaces start flooding with blood, driving the air out of these alveolar spaces, hampering the lung function. So, example, left heart failure, mitral stenosis, pulmonary vein obstructions, thyrotoxicosis, or cardiac surgery, nephrotic syndrome, and obstructive lymphatic outflow or cancer, or sometimes inflammation can result. So, increased vascular permeability results to damage in the vascular endothelium as well as the alveolar epithelium. This increases vascular permeability. Excessive fluid and plasma proteins leak out initially into the interstitial and subsequently into the alveolar spaces. Example is fulminant pulmonary and extrapulmonary infections, inhalation of toxic substances, aspiration, shock, radiation injuries, hypersensitivity to drugs, or ataxia, or uremia and acute respiratory distress syndrome. Now, so acute high altitude edema is individuals who climb high altitude suddenly without arts and without waiting for the acclimation suffers from serious circulatory and respiratory air effect, particularly at the height of 2,500 meters. These above sea level, these stages include pulmonary edema, congestion, widespread hemorrhage. These stages can cause death within a few days. The underlying mechanism appear to be anoxic damage the pulmonary vessels, resulting, however, it can acclimation to high altitude is around to take place. The individual develop polycythemia, raised pulmonary arterial pressure, increased pulmonary ventricular ventilation, and raise in heart rate, and increased in cardiac output. So these are the different options, basic pathology and actions where you can get that information from. Thank you very much for listening to us. Next time we will have a discussion on the opposite of edema, which is shock. Continue listening to our lectures, subscribe to our YouTube channel so that you can continue getting information about our health for purpose of our life, for purpose of passing the exam. Keep on touch. Thank you very much.